Welcome everyone. Welcome to the symposium called by Preventing Bacterial Infection, a Crucial Front in the Fight Against Sepsis and Antimicrobial Resistance, organized by Sepsis Stiftung in collaboration with SepsisMID Global Alliance and supported by Sanofi. It is my privilege to introduce myself. I'm the ESCMID appointed chair. I'm Michele Bartoletti. I'm an infectious disease doctor from Humanitas University in Milan, Italy. And I have the privilege also to introduce my co-chair, Mariam Jashi, which is the CEO of Global Sepsis Alliance and the former Ministry of Health of Georgia and a member of the parliament. Before we get started, I think Mariam could introduce the work of Global Sepsis Alliance. So please, Mariam.
Thank you, Michele. Dear colleagues, esteemed delegates of ESCMID, we rarely have the opportunity in our professional lives as the clinicians, researchers, political leaders or innovators to save millions of lives. And this opportunity that we currently have is related to the need for reinvigorated action against sepsis, that is the major killer of children, women, and men worldwide. In fact, every year, sepsis affects 15 million children and adults worldwide, primarily in low and middle-income countries. And it takes at least 13.7 million lives annually. 8.8 million out of the 13.66 million sepsis-related deaths are related to bacterial infection. And the famous 4.95 million AMR-related deaths directly attributable or associated are part of the 13.66 million sepsis-related deaths. That is why we use every single forum to speak about the sepsis, the global health threat and medical emergency that is not adequately positioned in the global health or political dialogue. Every fifth death globally is related to sepsis. Heterogeneity and complexity of this clinical condition, of course, you know, is extremely complex, and that is why we need holistic, integrated approach that will cover the prevention of bacterial and other infections, synergies with antimicrobial resistance policies and action, investments in new prevention modalities such as new vaccines or other IPC solutions, new diagnostics for early detection of sepsis, new therapies, both antimicrobial, immunomodulatory, precision medicine, and post-sepsis care of the survivors. That is why I'm delighted to introduce to you the 2030 Global Agenda for Sepsis, the very first multi-year global strategy that the Global Sepsis Alliance launched at the German Parliament in September with engagement of more than 70 stakeholders and support from World Health Organization. I very much encourage you to visit the Global Sepsis Alliance site and see the agenda that you will find very much related to the work that you're doing as infectious disease specialists working on the bacterial infection prevention, antimicrobial resistance, and other sepsis-related aspects. Hereby, I have the privilege to introduce our brilliant speakers and panelists. GSA is the largest professional network of both sepsis experts and sepsis survivors and families affected by this medical emergency. And to showcase the face of sepsis that affects up to 50 million lives every year, I would like to share with you the video address from Uwe Wiermann from Germany. He is the example of how sepsis changes the lives of patients and their families. And Uwe is the regional director of the Amputee Association of Germany.
Hello, my name is Uwe Wiermann. First of all, I would like to apologize in advance for my insufficient English and my beautiful German language. When I turn 60, I want to get tested for a prostate cancer because my father was diagnosed with it at that age. I went to a neurologist. He performed a prostate biopsy because my test results seemed concerning to him. However, the same value is also relevant for lung health, and I have chronic bronchitis. Since I didn't know what to expect, I agreed to the producer rather naively. The next day, I got fever and chills, and my wife took me to an hospital in Troisdorf. It was a small rural hospital. The admitting doctor was the first to suspect sepsis and recommend that I be admitted. I followed his advice. Upon arriving at the ward, the first thing I heard was that there was a staff shortage and that they wouldn't be able to take proper care of me. I cannot remember whether I was given antibiotics or if any examinations were conducted. The only thing I recall is that when I report a high fever to a nurse, she handed me an ice pick. That was all. That night I collapsed and I had to be resuscitated twice, multiple organ failure. I was placed into coma. I woke up from the coma after 9 days. On February the 9th, 2018, in the hospital of Cologne, my family has gathered around my bed, and the first thing I am said to have uttered was, "Life is beautiful." And that's absolutely true. I was still heavily sedated, which made my re-entering into life easier. I often experienced strong hallucinations. After a few days in the intermediate intensive care unit, I was brought before a panel of doctors who looked at me with serious expressions that explained to me that my legs and my hands would decay and would eventually have to be amputated. I didn't believe them any word, but it was true. My legs kept turning into darker, and so did my arms. It was not a pleasant sight. I was sent to the university hospital, to my small hospital in Troisdorf, to decay as it failed. I lay there for another 2 months before returning to the university for amputations. This is not a pleasant sign. But 5 or 10 years ago, everyone with these conditions would have died, said Professor Pronkwall before the operation. My inner blood circulations have been strengthened. But as a result, the other extremity were no longer supplied with blood and began to die. The amputation of both lower legs went smoothly, but was still extremely painful. After the operation, I screamed the room down, and in saying what a human being can endure because the anesthesia didn't work. After about 2 hours, they finally found the responsibility anesthesia doctor with the pain medication, and I was to be able to drift off into my first arms. 4 days later, I stopped taking the medications because the nurse warned me that I might become addicted. Everything is possible. After 2 weeks, I was transferred to Reha in Utrecht. There received my first interim produced on May the 15th. I was able to stand up again for the first time. The people of Utrecht taught me how to walk again. The amputations of my finger followed in June or in July 2018.
As mentioned, Uwe is the face of our patients, and this happens in Germany. And similar to other high-income contexts that are much well-resourced to manage clinical aspects of sepsis. However, even in Germany, over 100,000 people die from sepsis. And Uwe, despite his amputation of the lower legs and his fingers, and who managed to maintain an amazing sense of humor and positive outlook to the life. He's the lucky one. Our amputees, our sepsis survivors, they always highlight, despite all the challenges they went through, they're the lucky one and they're fighting to save millions of others. I also have the pleasure and honor to introduce our leading experts and renowned researchers in the field of sepsis, today representing the European Sepsis Alliance, part of the Global Sepsis Alliance. And our first speaker is Professor Antonio Artigas, Professor of Applied Physiology and Chair of Sepsis and Acute Respiratory Failure Research at the Autonomous University of Barcelona. Professor Artigas brings more than 50 years of clinical management and research experience focusing on the acute respiratory diseases, sepsis, and he's the recipient of multiple awards and recognitions, more than 200 publications. And we have the honor to have Antonio as the board member of the Global Sepsis Alliance. Professor Artigas, the floor is yours.
Thank you, Mariam, for this nice introduction, and it's a pleasure to me to participate in this very interesting session, and to thank the Global Sepsis Alliance to invite me to be here. So in the next 30 minutes, they told me, I will try to summarize you the sepsis susceptibility and the comorbidity. I mean, what are the risk factors of patients to develop sepsis? These are my potential disclosures, but are not related to this presentation. And I will summarize to you and review the epidemiology that Mariam said something already, the risk factors, how we can detect these patients early, the role of age and comorbidity, the relationship between inflammation and organ failure, and finally some message at home. So sepsis is a very frequent disease, much larger than other well-known or probably better-known disease as cancer or AIDS. And I think it's important that 85% of the cases are present in low, middle income countries. So in this area are the really risk, patients with high risk to develop sepsis. What are the factors determine the incidence and the case fatality rate of severe sepsis? There are three main areas. The first is the host, the social and demographic factors, mainly the age, but also the sex, and the lifestyle, and some biological factors, the immune response to bacteria, the response to the treatment, and the chronic health disorders that are very frequent in patients, especially in elderly patients. The other risk factors are related to the pathogens. The distribution of the pathogens are not exactly the same, can be gram-positive or gram-negative bacteria, and these make a difference and will impact mainly on the risk to develop and to progress from infection to sepsis. The antimicrobial resistance, and finally the healthcare system that also may influence on the incidence of sepsis, the facilities to treat these patients, as you already heard from this patient, the quality and timelines of sepsis care, and the extent and quality of care for chronic medical disorders. These are the three main areas that will influence on the risk to develop sepsis and are very important to take in consideration if we want to prevent this disease. Sex and age are clearly related to the incidence of sepsis and also the mortality. Male has a higher incidence and a higher mortality if you compare with the female, where you see the incidence and the mortality rate is lower. And the higher is the age, the higher is the incidence of sepsis, especially when the patients are elderly, older than 65 years old. What are the factors contributing to the high incidence of sepsis and mortality in all patients? First is the immune response. These patients they have that we call the immunosenescence or the inflammation, the impairment of local immunity, especially in the lung. They have poor nutritional status. Many of these patients are associated with many comorbidity that will influence on the immune response. They have a low physiological reserve. Some of these patients, they have long-term invasive devices as catheters, and they have resistance strains because the previous antibiotic treatments in these patients. And these patients are difficult to detect because the symptomatology and the signs are completely different if you compare with young patients. So elderly patients are characterized by an immunodepression if you compare with the young patients. And if you see the response of the immune system is completely different if you compare with healthy young patients with, for example, a meningococcemia. If you compare with elderly patients with malnutrition and with chronic infection as a diverticulosis, or patients, elderly patients with diabetes and chronic renal failure or pneumonia. So these patients, they are not able to recover the hypoinflammatory response. Let me check this. And this is clearly related to a bad outcome. So the immune response in sepsis is an important area to identify and to understand the heterogeneity in host response to sepsis in these patients. And this will impact directly to the outcome of these patients. There are host factors related to the demography of the patients, the presence of comorbidity, the genetic and epigenetic and the therapeutic treatment, but also there are some factors as, for example, the different kind of microorganisms that are induce sepsis is completely different as Pseudomonas if you compare with the pneumococcus or meningococcus. The infection site is completely different if you look patients with pulmonary infection or a urinary infection, and it's important to take in consideration this. And also the disease progression of a stage and the trajectory. I mean, sepsis is not a static disease, it's a dynamic disease. It's important to see and to follow the progression from an infection to sepsis with a clear identification of an organ failure. So this is very important because, and I'm sure that the next speaker will precisely indicate this, but if we are able to identify the immune response of these patients, we can identify the different subphenotypes and facilitate a more personalized treatment of these patients. And the new technologies, especially the genetic technology, can also be very useful to identify, and I hope in the future it will be more and more implemented, to identify those patients that they have a high risk to develop sepsis. This is a case where they identify 4 gene signature in neonates with sepsis from the other neonates at the birth. And you see that the discrimination power of these 4 genes that were identified is extremely very, very important. That means that we can, in the future, using the new omics and develop a new system of point of care that to identify those patients that they have a high risk to develop sepsis and then to try to prevent this. Sepsis is related to the presence of organ dysfunction, and normally in clinical practice is identified by the symptoms and clinical signs for the brain alterations, the pulmonary organ dysfunction, or hepatic or cardiovascular, and so on, and coagulopathy also. But the most important is that the immune response is completely directly related to the degree of organ dysfunction. And as you see, these are recent data that are already published from time 0 in the emergency room at 4 o'clock and 24 hours. There is the same tendency, the same trend of relating the immune response and the level of organ failure. So this technology will help us also to identify the evolution of from the sepsis to sepsis in these patients. Acute kidney injury is one of the most important organ dysfunction in patients with sepsis. 34% of the patients with sepsis present an acute kidney injury. And acute kidney injury is related with higher mortality if you compare with patients that they don't have AKI. And can we predict this at time 0 in these patients? And the response is the new technology from the lab also can help us. And this is a study that we did with John Kellum in the United States, and we were able to demonstrate to determine 2 biomarkers, the combination of 2 biomarkers that we call the NephroCheck test in urine samples And these tests can determine the risk of the patients to develop an acute kidney injury. That means indicating that this could be very useful to identify those patients that will move from a suspected or identified infection to a sepsis together with an organ failure. And finally, of course, and especially in the ICUs, mechanical ventilation has a synergistic effect in patients with an infection, in increasing the immune response and increasing the incidence and as a risk factor to develop an sepsis. So just to finish, this is not a simple truth. It's rarely pure and never simple, as normally many diseases in our clinical practice. And with this, I will finish, and I'm happy to answer any questions from you. Thank you very much.
Thank you, Antonio, for sharing the wealth of your experience. If you could please sit for the panel, we hope to have at least 10 to 15 minutes of Q&A sessions. Our next speaker is Lisa Mellhammar, Associate Professor and Senior Consultant of the Infectious Diseases at Kane University Hospital in Lund. Lisa's research interests include sepsis epidemiology, long-term effects, and stratification in adults and children. And she will be speaking about sepsis, long-term mortality and morbidity in children. Lisa, yes, please.
Thank you very much. Yeah, so I think children is a patient group that should get a little bit more attention from us working with infectious diseases and sepsis. Of course, we have pediatricians, but at least where I come from, we don't have that many infectious disease pediatricians or intensive care pediatricians. And also the reason why I say that is that the study I'm going to present, when we applied for ethical approval, it was first denied with the motivation that sepsis in children is not a problem. And then, of course, we re-appealed and we got an approval. But I think that speaks for itself. So specifically, I will talk about long-term mortality and morbidity in children. So here's a picture from a paper by Hallie Prescott, and it demonstrates the health status before and after sepsis. So you see the health status on the y-axis, and it starts to the left, and it goes down and is worst during the sepsis hospitalization. And then after that, some patients recovers while others don't, and some even deteriorate. And we know that it happens for a long time in adults, both in terms of physical, cognitive, and psychological consequences. Okay, so, sorry. What about children? Well, starting with the incidence, we don't really know how many children suffer from sepsis yearly. Somewhere between 4 and 25 million. 25 million is according to the Global Burden of Disease study. And the same goes for mortality. We don't know. In some studies, it's a couple of %, and in some, it's a really high mortality. But it's because of, depending on the location and methods. Globally, we see a decrease in sepsis in children, but some countries actually have an increase due to more children living with comorbid conditions. But I think it's fair to say that we have a large number of young sepsis survivors. So the question is if they are affected by long-term consequences. And we know that they do. We know that a third of them do not return to their baseline functions within a year, and that's measured by health-related quality of life. And we also know that a fifth had progression or a new chronic condition within 6 months of hospital care for sepsis. And it was most often chronic kidney disease or respiratory diseases. And the fifth was readmitted within 90 days after sepsis, and it's most often a new sepsis, or at least related to an infectious disease. One study showed that late deaths are as common as early deaths, and by that I mean during and after hospitalization. But there are limited data beyond the first year, so we wanted to provide data on long-term mortality and morbidity beyond a year. And we also wanted to include a control group to compensate for confounding effects of the hospital care. So we did a nationwide retrospective cohort study from the beginning of 1987 to the end of 2022. And we linked register data on patient characteristic for pediatric cases with sepsis to a control group. And we used data from Swedish National Patient Register, which contains hospital discharge register and outpatient care register. And we also had data from cause of death register. And sepsis patients were identified using a combination of explicit and implicit sepsis codes. And explicit sepsis codes, that are the ones that actually codes for sepsis. It's the one you're supposed to use the recommended R codes, like R65 or R57, if you recognize them, it's for sepsis and septic shock. And then there's also the A codes, which stands for bacteremia, and B codes for candidemia. But the majority of patients do not acquire a sepsis code, so therefore there's another strategy called implicit sepsis coding, which is that you use patients with a code for infection and one for organ dysfunction. And I'm saying this because it might affect the results, because both these strategies have trade-offs in terms of sensitivity and specificity. Okay, and then we had a control group with ICD codes for organ dysfunction. And the primary outcome was all-cause mortality, and we had secondary outcomes, which were cause of death and new diagnosis. And we included 149,000 patients in this study, of whom 55,000 had in the sepsis group. And the majority was under 1 year. There were more boys in both groups. Malignancy was more common in the sepsis group, but most of the children had no comorbidities. Okay, so what you see here is the result, that children with sepsis have a higher mortality the first 5 years after sepsis. But after 5 years, there's no difference any longer. And also you have to remember that this isn't compared to healthy individuals. This is compared to the control group with an ICD code for organ dysfunction. And unadjusted, the hazard ratio is 1.5, and adjusted it's 1.2 when it's adjusted for age and comorbidities. So you might not think it's a high increase in mortality, but with a pediatric perspective, it's actually bigger. Because, you can think of years of life lost or something like that, and it's a bigger impact. Okay, so when you look at the causes of death, the big differences are for sepsis and infectious diseases. There are more malignancies in the sepsis group, but they were more common at baseline. So it's not that they got more sepsis after sepsis. We know that because we have the diagnosis. These are the ones after 1 year. They were actually even more common the first year, but we wanted to focus beyond the first year. So it is new sepsis and respiratory diseases that's increased. Yes, so once again, I like to stress that these increases in mortality and morbidity are not in relation to healthy individuals, so we might actually underestimate the disease burden. But the control group was there to compensate for potential confounding effects of hospital care. And also the fact that we included implicit sepsis coded patients, which we did to add sensitivity, but we lose specificity, so it may have delusional effects on the results. But I think we can conclude that children do suffer from long-term effects after the first year of the sepsis, but it's the first year that's most important. And there's a risk of new sepsis, and it may be preventable to some extent. So I think it's important that we follow up these children. And I don't think we always do that right now. So of course we need further studies, like if they enter a state of immunosuppression, and in that case different phenotypes, and if we can reverse it, things like that. So we're just scratching the surface here. And yeah, by that I'd like to say thank you for listening and leave the word to the next speaker.
Lisa, thank you so much for your truly groundbreaking work in the clinical epidemiology of sepsis and now focusing on children. Despite the disparity of data, we know that at least 40% of the global sepsis burden is in pediatric populations, and we definitely need to focus more on sepsis prevention and management in children. Thank you. Our next speaker is very well known to the ESCMID community as the recipient of the Young Investigators Award, the chair of the European Sepsis Alliance, professor of infectious diseases and internal medicine of the National University of Athens, Professor Evangelos Giamarellos-Bourboulis, who has 476 peer-reviewed publications with truly breakthrough work both in immunomodulatory and COVID-related research. Evangelos.
Well, thank you very much for the elegant introduction. Thank you very much, the organizers, for bringing me here today to present to you something which I believe is very important and which I've seen that is missing not only as a knowledge from the Critical Care Society, but also from the Infectious Disease Society. So, room for prevention from multi-drug resistant bacteria, this is a question mark. I have to disclose from the very beginning that I don't know the answer. The question is whether we can use our innate immune defense to train ourselves and to prevent that calamity. This is my conflict of interest disclosure for this presentation, and I would like to start with a poll. Do you believe that vaccines have non-specific effects and protect from multi-drug resistant pathogens? The answers you may get are yes, no, maybe in some cases. I don't know if you have been so far in sessions with these polls. What you need is to scan the IQR. I launched the poll, and I would like to ask the Chair, Mr. Chairman, from the moment that they see that there is a plateau in the questions, to notify me to stop the poll. So please, the poll starts and you may vote. Yes, no, maybe in some cases. May I stop the vote? Okay, so 57.7% believe that there can be some effect, and 34% they say yes. So that means that you have already set up the stage that many of you are aware of the fact that actually what we do with vaccination is that we expose in an artificial way our body and our immune system to an antigen, and we anticipate that when we come across a real virulent load of that pathogen, we may develop a secondary infection. However, what we can do, because always when there is a pathogen, and the immune system conceives vaccine as a pathogen, in order for the pathogen to end up with the production of immunoglobulins, first of all, there should be a process which is called antigen presentation. And this does not take place in lymphocytes. It takes presence in our innate immune cells, in the dendritic cells, and in macrophages. So, look what they do happen. There is a constellation of metabolic and epigenetic changes, and that's very important. Epigenetic changes means that the genetic machinery works, but in order to have a transcription of a gene, there are some proteins which they are responsible for the coiling of the DNA. They're called histones. And if there is a modulation in these histones, they decide on their own, when they come across a second antigenic trigger, of how much of transcription of the gene they will allow to happen. But until 2020, everything had to do with animals. Everything had to do with in vitro evidence. And all of a sudden, we decided, together with Mihai Natea from the Netherlands, who's the real mind behind that, to do a randomized control trial. But the question is, we want something important. In other terms, we vaccinate few and we get an important effect, or we vaccinate thousands of people and statistics help us, and an incidence of 0.5% between the two groups, just because you enrolled in the study some thousands, becomes of importance. In other terms, you need to specify the population you need to protect. Who this population should be? Patients aged 65 or more, who are discharged alive from the general ward. And of course, just because we decided to vaccinate with BCG, we had to screen by IGRA test, and we had to exclude almost 30% of our adult population in Greece because they were IGRA positive. And the primary endpoint is the time to the first infection. After a follow-up, not of 4 or 5 years or 10 years, just 12 months are enough. So we want small numbers and have that pragmatic. And look at the results. The incidence of a new infection took place in almost 42% of those vaccinated with placebo, compared to 25% of those vaccinated with BCG. The odds ratio of protection is 0.56, and the two most important comorbidities which drive towards new infections are chronic renal disease and COPD is important. And then the question comes, are all infections prevented? For instance, if you have an anatomic abnormality in your urinary tract system, can you be protected from urinary tract infection? If you have sutures in your gut, can you be protected from an episode of ileus? Or perhaps just because we are inherently brought up to be protected from respiratory tract infections, all protection has to do with that. So this is the meta-analysis within the study. You see that all respiratory infections of probable viral origin and overall all respiratory infections, cap or non-cap, are those for which most of benefit comes. And now I want a second poll from you. How this came out? How do you believe this BCG vaccination protected from secondary infections? And I give you 4 options. BCG-induced anti-inflammatory responses to non-BCG antigens. BCG-induced moderate pro-inflammatory responses to non-BCG antigens. It induced major pro-inflammatory responses, or we believe that probably this is far too imaginary to happen. So this is the poll, and these are the options. May I end the poll? So, the vast majority, 66.7%, believe that BCG induces moderate pro-inflammatory responses to non-BCG antigen responses. So, this is what happened in the patients 3 months after vaccination. Vaccination either with placebo or vaccination with BCG. We collected from the patients PBMCs and we stimulated with stimuli that have nothing to do with BCG. So LPS, targeting POMC here, targeting TLR2, which, and you see there, an increase of the production of IL-1 beta. Candida albicans, targeting beta-glucan and in part TLR4, although originally that appeared not to be the case, and you have an increase of the production of IL-1 beta, and again with Candida albicans, increase of the production of IL-10. So you have here increase of the production of TNF, IL-1 beta, which are pro-inflammatory, but also IL-10, which is anti-inflammatory. In other terms, you don't have a favorable response towards the pro-inflammatory or the anti-inflammatory arm. What you get is an orchestrated pro-inflammatory, anti-inflammatory balance, but at a more enhanced stage, which allows the prevention of infection. And this is how this is happening. These are epigenetic modifications. This is the acetylation of histone 3, and you see that in the BCG group, regarding what is happening just before the promoter of IL-6 and TNF, this goes up. And then, after we had this data, we decided to move along to a similar randomized control approach in patients with COVID-19. Our idea originally was to vaccinate 1,000. We had to stop to 301 just because the vaccines arrived. But until the arrival of anti-COVID vaccines, we managed to vaccinate 152 placebo, 146 BCG. You see that, again, we targeted patients aged 50 or more with a lot of comorbidities, mainly heart comorbidities and COPD. And look at our results in the intent to treat population. The primary endpoint was set on day 90. There was a trend towards protection. But you see that long-term, until 6 months, the incidence of COVID-19 went down. And these are the results, taking into consideration the 3 randomization strata, which were coronary heart disease, type 2 diabetes, resistant hospitalization, and the variable which protects from COVID is BCG vaccination. So I promise that I cannot bring evidence for MDR. But we know very well that MDR pathogens, they love the lung. So I believe that we have true clinical evidence that vaccines for respiratory infections, BCG, it could be the case for RSV as well. It remains to be proven. They may train innate immune responses. They provide balanced immune responses to secondary infection. Protection is mainly for respiratory infections, and actually, protection has to do with patients aged 65 or more with comorbidities. Thank you very much, and I'm looking forward to the discussion under the hope that with that approach, we may prevent hospital-acquired infections by multidrug-resistant gram-negatives.
Thank you, Evangelos. And building on your presentation, let us highlight that immunization against existing vaccine-preventable diseases, as well as investment in new vaccines, is one of the strategic pillars to fight against sepsis. And let me hand over to my co-chair, Michele, for the Q&A session.
Yep. I don't know if there are any burning questions from the attendees. I don't see anyone. So I will start with some questions. Antonio, what's the role in controlling the inflammatory response in sepsis? Where are we now? Can we use some drugs to control inflammatory response in sepsis?
Well, to control the infection and to prevent evolution to sepsis will depend where is the patient. If a patient is in a low income countries, probably the most important is to wash, to have to prevent the infection or the conditions where these people are living, more than to have to give fantastic vaccine or fantastic immunomodulator treatment. If we are doing, or we are thinking in countries that are, well, more developed, as for example in Europe or USA, I think the most important is to early detection of these patients, especially in early, I mean, in the first hour, if it's possible, or during the first 3 hours, in order to start immediately the antibiotic therapy according to the pathogens that are in this hospital. But we need to improve the technology, and I'm sure in the next 2 or 3 years we will have point-of-care systems that will define exactly what is the risk to progress from an infection to a sepsis, and also to define or to have a more clear picture of the immune response in order to decide a more personalized treatment. But early detection in the first hours, I think, is a key, and we are waiting for new technology, how to apply this, and I know that there are some groups that are working hardly on this area.
Thank you so much. Lisa, what are the differences between adults and children in sepsis, and also in terms of prevention to establish the response to vaccination to a potential candidate to vaccine candidate for sepsis in children?
Yeah, I think it was you who showed a nice picture how patients respond differently. With some patients have a really high inflammatory response, and others have a lower, and some even have a compensatory anti-inflammatory response. And children, I mean, they are so they have such a healthy immune system that they react a lot, and I don't know really if that's good or bad, because they're on the same time they're really resilient, but they also, I mean, it's the immune response that's the problem partly. So it differs from adults, but hard to say which way. We need to go into that further, find subphenotypes and stratify them, I think.
Thank you so much. Evangelos, why is it so difficult to find a good vaccine candidate for multi-drug resistant pathogens or for bacterial infection compared to viral infections? We know that we have a lot of trials that fail to demonstrate an efficacy in some vaccine candidates, and why this happened for bacterial infection?
Well, thank you very much. This is, a difficult question, and only really speculations can be done. But I believe the real reasons why patients are infected by MDR is because somehow they come in contact with the hospital environment, and in the majority of the cases they are either colonized by this type of bacteria, and there are either instrumentation or interventions or a derangement of what is called the normal anatomic barriers, which cannot be prevented by vaccines. However, I believe that in these cases, what we need to do is to take advantage of the properties of the vaccines so that when these patients are infected or reinfected, what they come across is an attenuation of the degree of the inflammation induced by this MDR. And I believe that the important thing coming out of our studies is that we need to, as ID specialists, to reinforce the belief of the world to vaccination, not just because vaccines, they provide protection against the specific antigen or the specific infection which is on the SPC license of the product, but because it provides a general improvement of the physical shape. And this is something which needs to be expanded and to become more and more known.
Thank you so much. But I have an additional question. For everyone, I strongly believe what you said right now, but how can we convince people to get vaccinated for sepsis or for this purpose without any direct evidence for prevention? I think it will be very challenging in terms of vaccine hesitancy, what we are seeing now from our population. What do you think about this?
Well, may I? Well, actually, I believe that what is needed, because this is non-specific, and the mentality which I fully understand behind any manufacturer is that I want to show to the world that I brought a vaccine which protects against my specific disease. I believe that all of them needs to be united and to have a large-scale trial trying to see in a very broad way how respiratory infections, which are the main culprits of sepsis, can be prevented. But I would like to listen also to the opinion of Professor Artigas, who's by far the more experienced in respiratory infections.
I fully agree with you. I think if you compare, as I mentioned previously, the sepsis from pulmonary infection compared with other infection sources are completely different. And the more severe and related with the high mortality are the respiratory infections. Because respiratory infections has a peculiarity is that there is a compartmentalization of the immune response. And if you compare, for example, to urinary sepsis or abdominal sepsis, these are completely different. And just to answer to your question, I would prefer to focus my research in this area, because it's the area that is related to higher incidence and higher mortality rate.
Thank you so much.
Listen. Yeah, okay.
So we are...
May I ask a question to the pediatrics?
Yes.
Because, well, but probably you know, I think we are admitting more and more children with cancer and with treatment that are influenced or they have an impact on the immune response. Do you think that this could be a risk factor also to develop a sepsis and probably to prevent this in this specific target population?
Yeah, I think so. I really think so. I mean, all cancer treatments, they have gone really far, but they still have the problem with immunosuppression and neutropenic patients and all these complications. And I think that's something that really needs to be addressed. I think it's a really big burden of disease in the cancer patients that, yeah, we give some of these colonies, what do you call it, stimulation medicines, but that's all, actually. So, yeah.
Okay.
Just 30 seconds.
Yeah, okay. Filip Pirlejewski, I'm a pediatrician, I'm oncohematologist. That's not really true that we are having like more patients with cancer, because the frequency of cancer patients in pediatric is quite stable. It's like generally not changing too much. So maybe the importance is that our therapies are very, very severe, or simply we go further with the diagnostics a little bit. And that's why we have like a more proper data. But to be honest, the epidemiology of cancer is not changing the picture here in the sepsis scenario.
But they survive longer with better treatment.
Yeah,
with
of course.
Some kind of immunosuppression for.
Yeah, the number of survivors is also growing up in pediatric oncohematology, although we are reaching some kind of a ceiling right now, but it's still a huge number of survivors.
Thank you so much. Unfortunately, we have to close the session. Any closing remarks?
Just to thank our wonderful panel of speakers, thank you very much. To thank Sepsis Stiftung and Professor Konrad Reinhardt, who was not able to join us today, but for co-organizing the session. And of course, to thank Sanofi for supporting the session, and to use the opportunity to invite all interested players and stakeholders to join the Global Sepsis Innovations Platform that we established recently under the umbrella of the Global Sepsis Alliance, to discuss on unmet needs in sepsis prevention, new vaccines, diagnostics, and treatment. Thank you very much for your attention.